From haloperidol to multiple injections, anything but the opioid, that's what we're talking about tonight on the Dr. Dustin Show. Hello, everyone. Welcome back to another episode of the Dr. Dustin Show. I am Dr. Dustin, a double board certified pain management physician. And if you are a pain patient watching this for the first time, you probably know that anytime you go around the corner looking for some relief, you immediately get a sign in your face that says, sorry, but no opioids. Well, we've talked about this concept a lot on this channel. Anything from forced tapers to punitive questionnaires that have to do with opioid risk, even the feeling that you get when your medications are being held hostage, unless you do whatever the procedure is being demanded of you to do. And, that's just not good medicine. But unfortunately, this sort of movement is across the medical field as we know it, not just regulated to pain management. One such instance is the regulation, distribution, prescription, if you will, of opioids that come from an emergency department. Okay. Now, again, many of you already know about this. There's several ERs and emergency departments that pride themselves really on not giving out too many opioid medications. In fact, some even advertise themselves as being opioid-free ERs. Well, while the intent might be good, of course, we don't want to overexpose anybody to opioids or potentially cause an overdose or something catastrophic. Isn't that kind of what the ERs are for, to treat pain, especially severe pain? I mean, I couldn't imagine if I went to the ER and had severe 10 out of 10 pain and they're like, yeah, here you go. Here's some Tylenol. Well, that is the conclusion of what one recent article came out with. This narrative was put together by Pat Anson entitled "More Non-Opioid Drugs Recommended for ER Pain Relief." And it was essentially a description of a study recently published in the Western Journal of Emergency Medicine, where they attempted to find and list the best, most effective non-opioid medications for the treatment of pain. Now, they actually found over a dozen medications that were supposedly effective for 5 specific conditions, one being back pain, abdominal pain, chest pain, fracture pain, and headache. Okay. Now, originally they looked at about 246 studies to sort of put together their study, but after applying their inclusion and exclusion criteria, they came down to about 23. And what they found was that most of these medications were basically Tylenol or nonsteroidal anti-inflammatory drugs, such as ibuprofen, naproxen, things of that nature. Imagine going to the ER and they're like, yeah, here's some Tylenol, here's an ibuprofen. I mean, holy cow. Like, that might be appropriate in certain circumstances, of course. But it just seems like, to me, just knowing what my patients go through, we're already well past that stage. They probably already tried that. It's like, you broke a bone, here, take some Tylenol. Okay, well, again, depends on the patient. Some patients do well, but to apply a broad protocol, I don't think so. Some of the other medications, though, did surprise me that made the list. The first one was haloperidol. Now, we've talked about haloperidol being more used as a non-opioid acute pain management medication. Now, haloperidol or Haldol is an antipsychotic medication. It's an anti-dopamine medication. So it's used to treat schizophrenia, agitation, even off-label for psychosis or Tourette's. But for pain, apparently, based on the studies that they found here, it can be helpful for both headaches and abdominal pain. So there you go. Okay. But specifically headaches or abdominal pain. They did not mention that it was helpful for fracture pain or anything else. Fibromyalgia, right? Fibromyalgia flares or radiculopathy, nerve pain, things of that nature. was not listed. And it makes sense because a lot of that pain follows certain neurologic pathways and uses certain chemical messengers that haloperidol does not even touch, which is why we know it doesn't work for fibromyalgia. They've already tried, among other things. So, but it does work for headaches because there does seem to be a relation, especially with migraines, with increased dopamine and nausea and things of that nature. And so even if you treat the nausea well, chances are the headache itself will improve. But some more surprising things here. Venlafaxine, which is a serotonin norepinephrine reuptake inhibitor, or an SNRI, was, while it is an antidepressant and anti-anxiety, they found that it could be useful for back pain. So there you go. Now, I'm not going to disagree with that at its face value. Venlafaxine, being an SNRI, is a sister drug to duloxetine or Cymbalta, which is another SNRI with indications for chronic pain, musculoskeletal pain, diabetic neuropathy, fibromyalgia, things of these nature. And, it works quite well, but it takes like 2 weeks for the thing to kick in. And then you got to titrate the dose over time. And so I'm like, okay, so you're going to use this like in the emergency room setting, like where you come in with, you were lifting a mattress and popped your back and, oh, here's an antidepressant. Good luck. Okay. No, I don't necessarily buy that one. Some other ones they found, ketamine was apparently useful for chest pain, abdominal pain, headache. Okay, cool. We like ketamine on this channel. We like ketamine in the clinic. And yeah, I mean, when it first came out, it was a dissociative anesthetic. It was used for combat soldiers who had suffered, major traumatic wounds. So yeah, I can see ketamine being useful in that setting. Of course, that's all dose dependent and whatnot. Benzodiazepines were apparently on the list for abdominal pain and for abdominal pain. So the fact that they included benzodiazepines on this list is again shocking to me, because benzodiazepines, if we didn't have opioids, we would have a benzodiazepine epidemic. Okay, but because we have an opioid epidemic, we don't ever talk about the benzodiazepine epidemic. But they have their own addiction profile, their own overdose risk, all these things. And so it's interesting that this made the list for abdominal pain in the setting of this very anti-opioid movement. It's like, well, don't take this poison, but you can take this poison. This poison's way better. Okay, all right. But again, benzodiazepines, the right dose, the right patient, there you go, can be effective for abdominal pain. And then metoclopramide, which is another anti-nausea medicine, can be used for headaches. So again, that goes along with the haloperidol. They're both anti-dopamine type medications. And so that seems to be helpful for the headaches. One that did not make the list, which was somewhat surprising, was gabapentin. Seems like everybody's on gabapentin, at least in the outpatient setting for chronic pain type stuff. But nope, they did not find it to be helpful for the 5 conditions that they evaluated. So, that's very interesting because, again, why are we trying to promote anti-opioid when we should be trying to promote pain relief, right? And the emergency department, that's where you go to get pain relief. That's where you go. There's chronic pain clinics and things like that, but we move slow. Right? Even a day or 2 or a week is very slow in the pain world. But that's just how the system, is that we operate in. But the emergency room is an emergency. And so, patients, you would think that they would love to live there, but they don't. That's one thing I think emergency room docs could maybe learn about chronic pain patients from a person that works with chronic pain patients. From what I learned, chronic pain patients don't like to go to the ER, right? I mean, think about it. You're in pain. You're in a lot of pain. And now you have to leave the comfort of your own bed with all of your own pillows and blankets and temperature and food and snacks and people and support and TV shows and distractions and all these favorite things in the comfort of your own home. Now you got to get into a car, drive across crazy traffic, go into a brightly lit waiting room that's probably loud. And then you got to convince the first person that you see that you're sick enough to be seen, because that's their whole job, is to basically judge you, which as a pain patient is traumatic in and of itself, because it's like, do I look like I'm in pain? How about now? Now, right? You got to feel like you got to put on the show to get believed. So then they triage you. You go sit in the waiting room some more on a hard chair in a room that's probably crowded with cough and sickness, and the bright lights are buzzing overhead, and it's either too hot or it's too cold, and you're sitting there for way too long. And then you finally get pulled back, and then you got to repeat the whole charade. Look, it hurts here. It started this. It did that. I can't do this. It's severe. I know I don't look severe, but it hurts like crazy. You got to do the whole convincing thing again. And then they come and bring you Tylenol, and you feel like you have to take it in order to, appease them, and then climb the ladder appropriately, because you can't just jump with, IV Dilaudid or whatever the case is. You have to work your way up, So it's a whole smoke show to just get a little bit of relief before you can feel like you can blend back into society or follow up with your doctor the next week. It's crazy. Now, are there some patients that misuse the ER? Of course. I actually worked in the ER, believe it or not, as a scribe back in college. That was one of my first jobs. In fact, I got to wear scrubs, so I remember being so excited I got to be paid to wear scrubs for the first time. And yeah, so I worked there for 2.5 years. And then when I was an intern after medical school, I worked in the emergency department at Parkland in Dallas for about 4 months. And so I know just enough about ER medicine to be dangerous, okay? Just enough to be dangerous. Definitely there's patients that shouldn't be there. There's no doubt. But a lot of patients really need to be there. And, so I think this just sort of falls into this broad scope movement, if you will, against any type of opioid therapy, just for the sake of moving away from it. It's interesting because the studies don't really support this. There was a 2024 study that found the risk of long-term opioid use after being treated with IV opioids in the ER is quite low. Less than 0.2% will go on to have problems after being treated with IV opioids in the ER. So again, what are we protecting? What are we trying to save, in the ER by not treating a large swath of patients that would actually benefit from it? This mirrored an earlier study out of the Mayo Clinic in 2017, and they found the risk of long-term opioid use, the risk of long-term opioid use. So you weren't on opioids. What's your risk of being on opioids long-term after being treated in the ER with opioids? That risk is 1.1%. 1.1%. And that's just the risk of long-term opioid use. That has nothing to do with the risk of developing an opioid use disorder or even developing addiction or overdose, experiencing an overdose. So again, what are we trying to save? We are going to give people that come in with back pain, acute back pain, so bad they had to go to the freaking ER, okay? And we're going to give them antidepressants or an antipsychotic. It's ridiculous. It's just ridiculous. Now, on the other side of the game, right, you have pain management clinics pushing procedures or holding your prescription hostage, right? This is the other side of anything but the opioid, okay? Now, we've talked about this before. In fact, I made a response video a few weeks back talking about how doctors actually don't get rich by forcing procedures. And I do stand by that to this day. However, if you are performing hundreds of thousands of these injections, then yes, you can get quite wealthy. And that is what this one clinic known as Pain MD did a few years back. Really quite crazy. The company president, Michael Kessner, I don't know that he was a doctor. I don't think so. But he was found guilty on 13 felonies when they found that his company was giving patients about 700,000 total injections over about 8 years. And some patients got as many as 24 shots at once. Crazy. Yes, let's see here. So the Department of Justice declined to comment. Kessner's attorneys either declined to comment or did not respond either. But at the trial, his attorney argued that he was just a well-intentioned businessman who wanted to run pain clinics that offered more than just pills. Okay, well, there you go. He did indeed do that. How about we just offer some logical pain relief? How about that? Crazy. Yeah, so there. Oh, hold on. I got to tell you this part. Yeah, this one patient was like, nothing seemed to help my pain. They just kept injecting me. It felt like they were using me. Yep, they were using you. No doubt about that. Yeah, they weren't even putting the shots where they were supposed to go. That's not any type of traditional medical practice. They were using medicines that did not have any steroid in them, which quite frankly is good, because if you're doing that many injections with steroid, you're going to run into a lot of other health problems. Sure. Yeah, so the company billed insurance about $40 million for 380,000 injections from January 2010 to March of 2013. So some quick math on that, it's about $100 or so per injection, which is what I was saying the other day. And as you can see, you really can't get rich on it unless you're doing hundreds of thousands. But even then, you can't get rich on it because they will shut you down, which is what happened here. Yeah, so listen, if your doctor wants to do injections for you, number one, it's a standard of care. We have good research and evidence and long-term experience to support the intervention that's being recommended in most cases. And, you know, we do it not because we want to make money. We're actually taking on quite a bit of liability, putting needles in your spine, right? Bleeding, infection, and nerve injury, and all these things. But yeah, we just don't get paid that much. We do it because we actually just want to help you. I know that's like hard to believe when especially you have docs like this or docs like that won't give you any medicine unless you do that procedure, right? And the forced tapering, holding your medication hostage. We've talked about that ad nauseum. But for a well-meaning pain physician who has the time and honesty to be transparent with you about what you're experiencing and what treatments might be recommended and be helpful for you, then yeah, you know, that's why we're doing it. We're not doing it to get rich. $100 an injection, like I said, it's $125 to write your prescription. Easy, right? So that's sort of where that goes. But again, you can't just throw 1,000 injections at somebody and then expect the system to even allow for that. Now, we want you off of opioids. Yes, true. We do want you off of opioids, not because we don't want to, we don't want to treat your pain, or we think that you're going to get addicted or have an overdose. Yes, those are thoughts. Those are considerations that plays into the medical decision making, of course. But that's not the main reason. The main reason, like I said, we just want you to get better. That's why I entitled my company Eclipse Pain and Recovery, right? It's about reducing dependence on the system. And so, being out here in Texas, I'm surrounded by, what you might call preppers, right? This idea that I don't want to be dependent on the system. I want to be independent. I want a well on my property, and I want chickens and chicken eggs, and I want solar panels and my guns and my Bible, and I could survive any zombie apocalypse, right? Like, there is something inherently American about that sort of fierce independence, That's a great thing to pursue. The challenge with being dependent on medications is that those medications may not be there one day. We don't know what goes on in the world. Tomorrow we could be at war. The next day we could be at peace. The next day we could be attacked. The next day we could attack somebody else. And supply lines are all, disrupted by this. Domestic production is under constant attack or priced out of the market. And we're seeing this already with opioid availability, right? How many times do you get a prescription? You go to the pharmacy and the pharmacist is like, sorry, we don't have that in stock. You need to try something different or go somewhere else, right? So you call 10 different pharmacies before you can find it. And then you have to make sure the prescription gets sent there quickly because, if it takes a day or two, then somebody else is going to get there and take the remaining supply. So we're already there. If anything, that just needs to hasten the pursuit of, we'll call it medical independence. But that's not because necessarily opioids are inherently bad. It's just there's so many considerations. There's so many health considerations, not even considering overdose and opioid use disorder. I mean, it affects your hormones. It affects your testosterone. It affects your energy levels. It causes you to be tired, fatigued, forgetful, insomniac. You will have constipation, and you're more likely to develop high cholesterol or diabetes. So there's other health considerations that come into play when we're on these medicines long term. And again, if it's the only thing that helps your pain, you've tried everything else, okay, by golly, it's obviously worth it. But if you haven't tried anything else, well, I know you have. That's why you're here. But that's sort of the, that's sort of the approach on that. Even still, I don't think medication should be held hostage. And this is what happens. You do 380,000 injections in 3 years. I think that was across probably 3 or 4 docs. I'm not sure. That's not one doctor doing that. It'd be impossible. But yeah. So, you go from antidepressant, antipsychotic to hundreds of thousands of injections. What's wrong with just getting a prescription for opioids? Well, the last thing that we talked about was this idea of the opioid risk tool. Okay. And this is another thing. If you decline the procedures or you decline the non-opioid medications, or you're not a candidate for them for whatever reason, this is another way a physician may not want to prescribe you medication, and that's based on the opioid risk tool. So, we've talked about this before. The ACE score is perhaps one of the most nefarious ways to risk stratify someone for opioids, mainly because it can use the presence of childhood SA, is my abbreviation there, in order to put you into a high risk category as an adult, and then use that as a reason to not prescribe, which is just terrible, because it's you're now a victim again of the perpetrator that was there in your youth. And because of that person, now you're not able to have access to stronger pain medication. Hold tight. I may have some good news for you. But yes, there are some other NARCS Care and EPIC opioid risk scores. A lot of these are built into our electronic medical record, or even the state monitoring databases for these controlled substances. Very interesting study came out in the Journal of General Internal Medicine. And what they found was, looking at 700,000 patients being treated by primary care, the vast majority, 99.6%, were classified as low risk, with only 0.4% considered at high risk for an opioid use disorder. Okay, so pretty good. Now, out of those patients that were deemed low risk, 2,100 and change went on to have an overdose or an opioid use disorder diagnosis within the next 12 months. So that means that the system correctly predicted outcomes 99.7% of the time. Conversely, of the 2,600 patients and change that were deemed high risk, only 185 later had an overdose or an opioid use diagnosis. So that means that they only correctly predicted the outcomes about 7% of the time for those that were deemed high risk. So if you're considered to be high risk, 7% of you are actually high risk. So this resulted in a pretty high false positive rate, no doubt. Most high-risk patients were false positives, and most who developed opioid use disorder or overdosed were false negatives. So out of the 2,300 and change patients who experienced an overdose or an opioid use diagnosis, the system flagged them they only flagged 185, which suggests that over 2,000 were incorrectly labeled as low risk. So there you go. Low risk does not mean low risk, and high risk does not mean high risk. And any well-meaning, well-educated, well-experienced, honest, and transparent doctor would know this. Now, I'm not saying this to argue with your doctor or demand prescriptions, because patients really, you can't force your doctor to do anything he or she doesn't want to do. That's just, it is what it is. But you can take this information and internalize it and know what your doctor's doing. If they're using this as a tool or a wall or a barrier to justify not giving you a prescription, then they are either uneducated or they're trying to find a reason to not give you a prescription. And at the end of the day, is that a doctor that you want to care for you? Probably not. Yes, pain management expert Dr. Lynn Webster says no opioid risk score should be viewed as authoritative by doctors and pharmacists in making clinical decisions. Boom. Both tools can be harmful if used punitively. Yes. Indeed. So that's the good news on tonight's show. We are not anti-opioid. We're not pro-opioid. We are pro-pain management. And, when we see a movement in the community that is basically anything but opioids, raises our little flags and says, is this logical? Is this scientific? Is it humane? And is it honest? And if the answer is no, then we're just going to call it to attention. But that's our show tonight. We want to continue helping our patients have some insight into this. Let me know your experience below. Have you experienced an ER that has not given you opioids or prides themselves on being an opioid-free ER? And if you've had multiple injections because your medications were being held hostage to the point where, you just felt like a human pincushion, let me know below. We need to bring these stories to light so that we can have a more honest and transparent conversation with our providers. So let's help each other live more with less pain. See you next time.